Otherwise, it's clear.
Excellent. That was a really good presentation, a nice summary, and probably as comprehensive as it needed to be. Talking to us about patient selection in CRT and giving us an idea on exactly which patients respond and which ones don't. My job today is to try and cover device selection, understand the technology in relation to CRT devices, maybe compare and contrast it with standard Brady pacing, and maybe re-emphasize some of the important messages that Dr. Hani has already shared with us. In order to do that, I'll just give you an outline on what my presentation will cover. We'll talk about the CRT efficacy paradigm, why CRT works and in which patients it works, and which technologies were originally devised in order to deliver CRT. We'll discuss non-response and the techniques and technologies that help address non-response. I'll talk a little bit about bipolar and quadripolar leads and about CRTP and CRTD from a technological point of view and discuss ICD technologies. Um, Now, going back to my first point, what is a paradigm for CRT? Well, to understand CRT, you need to understand that large, weak ventricles with left bundle branch block morphology are often desynchronous. There's a problem in the normal sequence of activation, and there are two things. The first one is that the synchronous contraction of both atria with an appropriate interval for filling of the ventricles from the atria is missing. And the second one is that the synchronous contraction of both ventricles and of both left ventricular walls is missing. And dysynchrony essentially means that there's an impaired diastolic performance and desynchronous left ventricular to right ventricular and intra-left ventricular contractility. And this systolic performance is therefore impaired. And the theory behind resynchronization therapy is that a device with appropriate timings and lead placements can address this. CRT is not 25 years old, it's now 31 years old. This is an old slide. I just want to remind everybody that the first CRT device was implanted in 1994. He was a 54-year-old man who had a very long PR interval and complete left bundle branch block with a QRS of more than 200 milliseconds. And in order to deliver CRT, this patient received 4 leads, almost in a temporary pacing configuration initially. And the leads were attached to a custom-made external programmable bipolar dual chamber pacemaker. There was a Y connector used to connect the both atrial leads and a Y connector used to connect both ventricular leads in order to fit into the socket that was involved. This was the original technology, and the proof of concept was improved when the technology was fused and moved from a temporary setup to a more permanent setup. Following that, of course, studies demonstrated that cardiac resynchronization therapy, even if it's just CRTP alone on the right-hand side, the CARE-HF study, was significantly better than medical therapy with a hazards ratio of about 0.6. And the guidelines came out. We've discussed the guidelines, and we also discussed the fact that up to 30% of patients do not respond clinically to resynchronization therapy. So I want to talk about non-response in CRT, and we'll talk about how these devices are set up to try and minimize non-response in resynchronization. The first reason for non-response, of course, is that the patient doesn't have sufficient dysynchrony. They may have a very narrow QRS complex, and they're receiving the device outlined outside the current guidelines. Patients would be, in fact, desynchronized if you put a device in. And so in this setting, absence of sufficient synchrony should almost certainly addressed by selection criteria that we currently use. Hani discussed failure to resynchronize, and I'd like to simplify it as saying that it is either related to a problem with the lead and the lead placement, and we'll talk about that, or insufficient biventricular capture. He talked about less than 90% biventricular capture in his presentation, meaning that you're more often than not, or more often than appropriately, going through the standard inefficient conduction system as opposed to the resynchronized conduction system set up by the device. And then finally, and more as importantly, the timing of filling, the diastolic performance, which I discussed earlier, can be suboptimal. And devices are set up to allow you to change the atrioventricular delay and also the delay between when the left ventricle and the right ventricle contracts. This is extremely important. And I think Hani talked about him and Mirvat occasionally using echo to optimize the device. Some of the elements involved in this require changing in the atrioventricular delay, the time when the atrial signal captures the atria, and the time when the both ventricles are resynchronized. That's the atrioventricular delay. And devices now will have the technological competence and software to support changing the AV delays from 0 as far as 350 milliseconds in order to find the sweetest spot that improves filling of the ventricle. Likewise, but maybe to a smaller extent, changing the timing between when the left ventricle initially contracts and the right ventricle can be adjusted by the devices. Failure to be synchronized, though, largely is given to certain characteristics related to lead placement. This is a paper I published with Andre Ng in, I think it was in 2008, highlighting the importance of lead positioning for optimizing the outcome of CRT. And here we have an MRI of a patient. On the left-hand side, the patient has a subendocardial scar. On the right-hand side, they have almost a full-thickness scar in the posterolateral wall. This is the area of latest delay in most patients with cardiac desynchrony, and this is the target sweet spot. If the lead was placed where the scar was, then you are less likely to resynchronize. You are less likely to capture. If the lead was placed where there wasn't a transmural scar, then the outcome in terms of cardiovascular survival was improved. Again, the site of latest activation is important. When the device or the leads are placed at the appropriate position, which is usually somewhere on the left-hand side, I'll try and put a pointer for those of you who are not familiar with these images yet. On the left-hand side is an RAO view of the left ventricle, and it's divided into what I would often describe as an apical two-chamber view with the base here, the middle part of the ventricle here, and the apical position over here. And over here, we're looking at the anterior position, and over here, the inferior position. And this is more like a parasternal short axis view with the anterior wall up here, the inferior or posterior wall over here, and this being the target spot in the left lateral wall. And this is usually the site of latest activation, and this is essentially where most of us are aiming to put our device, our lead. So lead placement issues are important. The Target HF study demonstrated that and demonstrated in many cases that there are multiple areas of late activation in the left ventricle. And in some cases, the need for multiple leads to resynchronize has been studied with varying degrees of success. But going back to the technology, the device originally was set up with unipolar leads. The original devices were unipolar. The bipolar leads appeared about, I think, 2001, something like that, 2000, 2001, this is a Medtronic selection of bipolar leads appeared. And they basically became the mainstay for CRT, and in most parts of Africa, this is the sort of technology that's available. Bipolar leads are sometimes misnamed. A lot of the time, we're talking about dual cathode leads. But essentially, the lead is placed in a lateral vein with this sort of separation between the tip and the ring of the lead. The key thing and concern around bipolar lead placement was that it only gave you a limited number of vectors, and the distance between the two electrodes was limited to only at most 23 millimeters. In the original pacing devices, this was the pacing polarity that you'd offer a patient. On the left-hand side, a CRT pacemaker by Medtronic would only offer you an LV tip to RV ring configuration. And many times you'd actually find yourself capturing the right ventricle and not resynchronizing. Or you'd go unipolar or bipolar, where you were capturing the tip to the ring. Of course, we now know that the lead placement comes with limitations in terms of the patient's coronary sinus anatomy and in terms of the position of the phrenic nerve and the risk of diaphragmatic twitch. Even on the right-hand side, the unipolar option, the so-called pseudo-unipolar option of LV tip to RV coil and LV ring to RV coil gives us relatively limited options with implant success rates of probably around 94, 95% without problems. Around 2010, 2011, the quadrupolar lead appeared. This is from the 2016 European Society of Cardiology More CRT trial, which looked at multi-site multipolarity pacing. And I'll just talk briefly about quadrupolar leads, which I think are hopefully going to become ubiquitous across our continent. The distance between the proximal and the distal ring, and there are four options, is somewhere in the 4.5 to 5.5 centimeter space. And the leads allow us to now get our lead into a very stable distal apical position and consider different pacing vectors. You can actually find up to 10 different pacemaker vectors to capture and effectively resynchronize from multiple different spots. The apical position, as I've mentioned, is good for stability while providing a more proximal pacing site. And the largest series of patients previously studied, 175,000, mainly elderly patients under Medicare in the US, demonstrated that these quadrupolar leads are effective at reducing the implant failure rate. Assuming that you were able to complete this, and of course, this is a registry, so it wasn't intention to treat, but as delivered, there was no difference in mortality. What that means is that patients who were successfully implanted with a bipolar device, which were fewer in percent than those who were successfully implanted with a quadrupolar device, what it means is those patients didn't have a difference in mortality because the bipolar lead implant was successful. The advantage, of course, being in the group of patients in whom bipolar lead placement was not possible, but a quadrupolar lead placement was. It's important to note that quadrupolar leads are slightly bigger than bipolar leads, and in some instances, the veins into which they're supposed to be placed are too small. Just a couple of practical tips after the implant to help address non-response, which we won't have an opportunity to cover later on. As Hani discussed, make sure that you are pacing both ventricles as close to 100%. Check for left ventricular lead thresholds. Is the left ventricular lead capturing or not? Often the patient's own device, own intrinsic rhythm accelerates beyond that. So atrial fibrillation, ventricular ectopic beats, runs of couplets and triplets can affect whether you get biventricular pacing. Sometimes the device is over-sensing the ventricle, so the technology needs to be interrogated in order to ensure that it isn't allowing or ignoring active signals. And sometimes the atrioventricular interval in your device has been programmed longer than the PR interval, essentially, so that the patient's intrinsic conduction system overtakes it. And then the second thing to do, as Hani had suggested, is to use an echo or other technique to optimize the delays between the atrioventricular conductions and the ventricular conductions. I'm not sure who's speaking in the background, but if you can mute your mic, it'll be good for both of us, all of us. So this is a quadrupolar CRTP device, Medtronic. Unfortunately, my slides are many of the images we have that in my slide are Medtronic. Uh, there is no specific bias. It's just that they they appeared in the market earlier than other companies in East Africa, and at the moment they're one of three CRT device companies. But I think across Africa, more people are programming and implanting Medtronic devices than other devices. So there would naturally be a bit of a bias. St. Jude or Abbott, and of course, Biotronic being the other two very common providers. Boston Scientific haven't yet ventured into this part of uh, East Africa for device therapy. I just want to point out that the header for a IS4 lead, this is IS4 means a quadrupolar, looks like this. It looks not very dissimilar to the header for a DF4, which we'll discuss later. And then you've got the two bipolar lead placement positions for the device. I think Dr. Hani gave a really good summary of which patients should get an ICD and which ones could be considered for just a CRTP. And some of the things that we grapple with in East Africa include the cost, but of course, across the world, the risk of inappropriate shocks from a device with a defibrillator and the risk of arrhythmic death is higher. Some of the lead-related complications, including the coils that then create venous fibrosis and venous problems. And in addition, of course, defibrillator leads have a slightly higher incidence of failure, largely because they're bulkier and the insulation to protect all layers, all types of the lead can be problematic. But of course, on the other hand, you're preventing arrhythmic death. I find this quite a useful slide to help us discuss the technologies available. CRTP is probably more common in the public sector in Kenya than CRTD, and vice versa in the private sector. But there are many patients who benefit. In fact, compared to medical management, CRTP was clearly demonstrated in the CARE-HF study to be superior to medical therapy. So patients, particularly those with non-ischemic cardiomyopathy, with significant comorbidities, patients with psychiatric issues who should not be receiving defibrillators, and some patients who are more interested in quality of life rather than quantity of life are often offered the choice, and many of them will choose to go for a cheaper, smaller, and less problematic defibrillator. Or just to indicate that fibrosis, whether it's caused by extensive myocarditis or myocardial infarction on cardiac MR, is a good indicator of which patients are likely to run into problems with sudden arrhythmic death. I'll talk briefly about CRT ICD leads. On the left-hand side, we have the original, what we used to call the IS1 DF1 leads. This would be the lead that would, this part would go to the patient, to the ventricle, and it would trifurcate or bifurcate. It would trifurcate into a pace sense or IS1 lead, and into either one high voltage lead if it was a single coil lead, usually the right ventricular coil, or two high voltage leads if it was a dual coil lead. And it would be connected to a 3-point header. So you'd have 1 point for the IS1 and 2 points for the SVC coil up at the top and the RV coil at the bottom. This was simplified again about 15 years ago into a single DF4 lead and allowed a pace sense functionality, which you could test a ring and tip here using the standard calipers, or sorry, tip and ring here, or you could do tip testing unipolar to the patient's pocket to establish whether or not you had good pacing vectors. So what is the advantage of DF4 versus DF1? Interestingly, there are actually advantages in both of these technologies. And I'll talk through DF4, which was the original excitement. The DF4 is smaller. It has fewer ports to plug in, so less likely to make a mistake while screwing the device in, the lead into the device. It's convenient at implantation because it's smaller. Therefore, because of the lead placement, it's not likely that you're going to get the high voltage pin switched in the wrong position because it's all placed in the same spot. And it occupies less volume in the pocket because the absence of the Y yoke, the Y connecting yoke that forces you into the trifurcation. But there are advantages in a DF1 device and a DF1 lead. And the devices will need to continue to be made for another 20 or 30 years because many patients have DF1 leads, and there isn't an appetite to create appropriate adapters to convert them into DF4 leads. The first one is patients who have recovered ventricular function and don't need an ICD can have a downgrade because you can plug the IS1 part of the DF1 lead into the CRT port, LV lead port. The other one is in this era of conduction system pacing, or in patients in whom you've placed an RV lead, but the sensing parameters at the apex are not so good. You can put a pace sense lead in the septum, useful in patients with RV dysplasia and or ARVC, and get good sensing parameters from the septum while being able to still shock by placing the coil at the apex. So you'd use an additional IS1 lead and ignore the IS1 port on the shocking lead. Also, you can switch IS1 pins in a CRTD with a bipolar left ventricular port. For instance, if there's an ICD lead under recoil. I set out to revise the CRT efficacy paradigm, to review the originator technologies, and to discuss non-response and techniques and technologies that help address non-response. We talked a little bit, as promised, on bipolar and quadrupolar leads and compared CRTP with CRTD and discussed the ICD lead technologies. Thank you very much. And I just borrowed this slide from Hani just to maybe re-emphasize, get the right patient, place the lead in the right space, and if necessary, use a quadrupolar lead in order to get your LV lead in an optimal position or to allow you to pace from multiple different vectors. Use the device programming functionality to address the atrioventricular and ventricular to ventricular delays, and make sure your patient is taking guideline-directed optimal therapy. Thank you.